Hi, this is Cindy, and welcome to Symptom Management for Grace House residents. When we talk about symptom management, we talk about how do we identify those, and those are signs and symptoms. And the difference is signs are things that you can observe. Example, somebody's sweating, and we check to see if there's a fever. That's a sign of an infection. If they're not putting out any more urine, or they haven't had to change the diaper in a while in the brief, then possibly kidney failure. Increased respiratory rate as they're laying there is a sign, obviously, of shortness of breath. They can't breathe, if they're struggling a little bit and can't do what they used to, those are signs that something's going on that we need to address. Symptoms are subjective. And what does subjective mean? It means that somebody's able to tell you or show you what they have going on and what their experience. Examples, the biggest one is going to be pain. Another one would be nausea. And it's usually described as the frequency, how often are they in pain, how long is it, and the amount of distress. So those symptoms are when we're walking into a room, we're looking and asking those questions to try to decide how can we make that resident the most comfortable. Why is symptom management important? Because it's our only way to make sure that somebody is comfortable. And one of our goals here at Grace House is that everybody is as comfortable and as pain-free as we can make it possible. So if we don't relieve symptoms, what's going to happen? First of all, they're not going to be able to do what they normally do during the day. It's going to interfere with their ADLs, activities of daily living. It's going to cause distress, suffering, and a decreased quality of life, which is what we're striving for, is for people to have quality at this stage. And then managing these symptoms quickly, identifying and looking at them, can help prevent a negative cycle of increased discomfort causing distress and anxiety, more discomfort, and then all of that leads to suffering, which we're trying to really avoid for these residents. The most common symptoms you're going to see in hospice are going to be pain, shortness of breath, anxiety, confusion, delirium, depression, fatigue, being tired, insomnia, they're not sleeping at night, they're sick to their stomachs, they're constipated, diarrhea, loss of appetite, dry mouth, unable to regulate their body temperature so that they end up with these really high fevers. And then obviously being incontinent of bowel and bladder is something that we always want to try to make it so it's the most comfortable for the resident themselves. These symptoms are going to look different on each resident. So we're going to give you some guidelines. And the idea is that the more experience you have working here at Grace House and through this Grace House certification and hearing it over and over again, you're going to be able to identify some of these. Some residents are going to be able to verbalize and tell you, yes, I am in pain and it's the worst pain I've ever had. Some aren't, right? And those are the ones where we might have to do a little bit more looking at them and assessing, so they're a little more moving around in the bed, those kinds of things that they're not eating now. Why aren't they eating? And trying to look at different signs as well as symptoms that we can see that we need to address. Those people that are unable to verbalize and can't talk to us, that's going to be your biggest challenge in trying to look at how to help them. One of the biggest things is we need to be able to recognize it, and then how do we address it? And that's what we're hoping to do with this class. Trying to, again, give you more ideas of what to do when you walk into one of those rooms and you can tell something's not right. And so that's kind of what we're looking at in this program. So what can be done to help manage these symptoms? So obviously we have medications, those as-needed medications, that are on the med charts, right? Where they're usually the narcotic sheets, There's also the pink sheets that have all of our as-needed meds. And they should tell you what those meds are for on those sheets. If they don't, you need to ask and make sure somebody's aware that it's not filled out appropriately. Also, being comfortable with what medication to choose. Sometimes there's maybe 3 medicines for somebody who's nauseous. So it's okay to make a phone call. That is also part of managing it. The biggest thing for you to be able to do is identify the issue, and then whatever way, whether you have a medicine or you need to make a phone call, you're able to address it. And then that way we can make sure that the resident is comfortable. There are numerous things you can do, and we're going to go through each of those that are just, there are meds, but then there's non-medication, which is called non-pharmacological interventions. So I'm going to start with pain, and we are going to do a deeper in-depth on pain during the CERT course, but I do want to talk about it right now as we're going over it. The residents can verbally rate their pain. What's your pain in your leg on a scale of 1 to 10? 10 being the worst pain you've ever had, 1 being essentially no pain. That way you're going to know if they're a 5 or a 6, then you need to give them something and then see if it works. So we're going to talk about that a little bit, of going back in to check to see, is the medication I gave working? There's also called a Wong-Baker Faces Scale, if you feel like that might be better for some of the residents. So it actually has a picture of their faces, and they're sad to happy. The biggest one I want to say, and we're going to put that up at the caregiver desk, is the FLAC scale for assessing pain in a resident that is nonverbal. And I think that's going to really help with those residents as they start to decline and can't tell you, and what do we need to do to help them. So those residents may be moaning, groaning, yelling, or calling out, furrowed eyebrows, facial grimace when providing care or moving them. The resident may appear unusually restless or agitated, and those are things we've seen, right? And so we're trying to identify, when you see that, what could it be? So this is a picture of both of those rating scales. Like the numeric one is 0 to 10 or 1 to 10. 0 being no pain, 5 being moderate, 10 is the worst pain. And that's something you can just do verbally, and it's okay to write that down, especially on those caregiver flow sheets, so that we know, is the pain getting worse or not? And if it is, and the medication isn't working, we need to let hospice know that. The Wong-Baker Faces Scale is down here too, and we will get those up and put those at the caregiver station too, so you can have it. The FLAC score is where you add it up. So you can see the category has the face. So you're looking at the face. How is the face? Occasional grimace drawn, frequent found, clenched jaw, or 2 points. The legs, what are they doing? The activity, are they crying or moaning? And are they able to be consoled, so calm down? Or are they content? You add that up from 0 to 10, and it's going to give you that same rating scale. An example would be, let's talk about Natalie. If you remember, her face used to scrunch up right between her eyes, and you could see it. That was a sure sign when I'd walk in that room that she was clenched and her face was all scrunched up, that she was in pain. So what is your responsibility as far as pain goes? You're going to have to identify a resident is having pain, and then the degree of the pain. And then also, are there physical things that we can do? An example would be pull them up in bed, get them off of a side if they've been laying on it, reposition their legs if it's their legs that are hurting. Is their catheter kinked? Is it causing discomfort and pain? Those are basic things that really can make a big difference. And then what are you going to do? You're going to go look at the med sheet and you're going to see what do they have as far as what's ordered for pain. And if it's the right time for the medication. You're going to give that medication if it's time and check back with the resident. It should take about 30 minutes and then to see if it's better. So you're going to say then, what is your pain now? Or is their face calmed down and relaxed? If it's not, then that means that pain's not better. And we need to not just stop there because we gave it, but look, is there something else we can give? Or should we call hospice and let them know that this isn't working? And sometimes they can do one-time doses or they'll send somebody out to take a look. So you can see you're going to first just be able to say, yes, this person's in pain or something's going on and it looks like pain. I'm going to kind of move them around, readjust them, and then I'm going to go look and see what they can have as far as the medications go. And then I'm going to give it, and then I'm going to make sure it's worked. If it hasn't worked, I'm going to need to do something else. And that can be as simple as calling the hospice. The interventions for the medications are going to be morphine, oxycodone, Dilaudid, hydromorphone, Tylenol for mild pain, hydrocodone, tramadol. These are all medications we see, and it really should say on those sheets, give morphine 0.5 mLs for pain. So you have it. Other things you can do is, we talked about turn and reposition, create a calm environment, distraction, breathing techniques, turning the lights down, decreasing the noise, sometimes a heating pad or ice. Be careful with those though, because those can cause burns. So you want to make sure that that's okay with the hospice to do that. So you don't want to just give medications. You also want to look at other ways to make them physically comfortable. The next one we're going to talk about is shortness of breath. So we're going to identify that, right? What are we going to look for? And you think it's easy, but it also doesn't always get treated the way it needs to. So rapid breathing patterns, they could come and go. So it's like they don't want to get up because they can't breathe. Those are times when they're still having shortness of breath, interfering with their ADLs, right? Because they won't get up because they're worried about their breathing. They may say, I just can't seem to catch my breath. They may appear restless or anxious. Think about it. If you're not breathing well and that's making you nervous because you feel like you can't breathe, they're going to be a little more anxious and restless, trying to find a way to get more comfortable. And then for the worst, they can display some bluish, purplish discoloration around their mouth. So what are your caregiver responsibilities and interventions? So if you're first to identify it, like we talked about, something's not right with their breathing. One of the biggest things, and we've seen this with our residents, I think it was Sarah, who we ended up, the oxygen wasn't working. The line had been kinked and the air isn't coming out. Those, their machines can break. So make sure that they're actually getting the oxygen they're supposed to be getting and it's on the right amount. And even if you have to pull it out of the nose and feel it on your hand, but you want to make sure that they're actually getting the oxygen. That's like easy fix. Turn on a fan, pull them up in the bed, raise the head of the bed, get some cool air in there. Think about it, if you feel like you can't breathe, what are you going to do, right? You're going to try to get some air. A calm environment. You can try some deep breathing with them. The anxiety is going to increase with the breathing issues. So our interventions for that are what I just said. And then the medications. You're going to do like a morphine or the hydromorphone with the Ativan also known as lorazepam, to help with the shortness of breath. You're going to use both of those together to help manage it. And as you know, those can be mixed and given. So those are the two big ones. Now, if that's not working, you're going to have to call hospice. Now, the other thing to not forget about are the duomnabs or any other breathing treatments they may have ordered. Sometimes they just need one of those treatments to open up their airways. So, doing the duonab and other breathing treatment might be all they need, not even the medication. So if you're going to have to look at both when you look at the med sheets to see what they have ordered. And try both of those. Again, if it doesn't work, you're going to let hospice know. So depression. This is a hard one, and it's going to be one where you're just you get a gut feeling, I think. There are frequent changes in their mood. They're expressing feelings of sadness, hopelessness, guilt, anxiety, staring out into space, not really wanting to interact, not really wanting to eat, loss of interest in anything that they even normally would have. The residents may have a change in their normal sleep pattern. They can't sleep anymore, or they're sleeping all the time. And we're kind of in that tough spot of just gut, like we get to know them and you're around them a lot and you're going to see some changes. And it's okay to let hospice know that you're starting to see that. And then the medications will be something the resident and the hospice would choose and get started. And then that would most likely be put in their med box, so in their pill box. So you might be able to see a change. Some other things you can do that aren't medication-wise are active listening, supportive present, actively engaging with them so they don't feel as alone, involving them, trying to get them involved in activities. If we have volunteers there, ask them to go down and see if they want to get them to go outside or up and sit in the main room, a game, coloring if possible, or watch a movie. Trying to get them to eat meals in the common area so that they're just not alone in their rooms. That can be very depressing too when they've gone from having an active life to being here at Grace House. Anxiety. The resident may be restless, irritable, express feelings of sadness, turmoil, excessive worrying about their lives and everything around them. You can see them sweat, nausea, heart palpitations. You can see them antsy, right? They can't sit still. They're up, down, walking around. Really a feeling of doom. And what are you going to do? Obviously listening, supportive presence, deep breathing. Obviously yoga and exercise is going to be tough, but we do have some mindful, like we could do an app on your phone that might help them with some relaxation. And then our biggest medicine that we're going to use, you're going to see, is going to be Ativan. I think that's the only one we've seen pretty much for the anxiety. And that's so lorazepam / Ativan are the same thing. And those are what we're going to use for that. So one of the big things that we've struggled with here, and you guys know this pretty well, is the terminal restlessness and delirium. So that inability to lay still, repeated attempts to get out of bed, taking off their clothes, picking, reaching into the air, up all night, hallucinations, garbled and confused speech, inability to communicate, changing levels of consciousness, which really causes family stress and exhaustion if they have family visiting. This is really one of the hardest things in many ways to be able to identify what's causing the terminal restlessness and how to manage it if we can't figure that out. So some basic things are, you're going to always ID yourself before touching them, even if they appear out of it. Make sure they're safe, Do not argue with them and avoid correcting them. There is nothing you're going to say that's going to fix this as far as them knowing where they're at. I would avoid reorienting the patient. The patient's unable to be oriented at this stage, and all it's going to do is increase it, because in their reality, it is what it is. And so you can't change that. But then you're also going to assess the physical reasons. And I think many of you have heard this in orientation, but I talk about the 3 Ps. So when have they had the last BM? If no BM in 3 days, you need to look for medicine for constipation. It can cause people to be incredibly agitated. Have they urinated? Meaning, if they have a catheter, is anything coming out? Is it clogged? Are there briefs on, but you haven't had to change them, and every time you've changed them, it's dry? That means that they're retaining urine. So that urine's being held in the bladder and they can't pee. Just imagine how awful that would be. Many times it can be because of pain medicine or the disease. Have they had their pain medicine? Big one. Because they can't tell you, and maybe they're having pain and they're trying to get away from it or figure out how to get comfortable. So those are the first 3 things you're going to address. Try the pain medicine to see if it helps. Look for the bowel movement, look for the urination, and then for the agitation, you're going to look for medications then for agitation and anxiety. So the Haldol is going to be the number 1 that we normally see the hospices order, and Ativan it can also be used. The other thing to think about if they're trying to get out of bed is if we can get somebody to sit with them, they can sit up on the edge of the bed. Sometimes having their feet on the floor makes them feel more grounded, so sometimes that's helpful. So we might need to look at volunteers or getting a second caregiver, something to help make them more comfortable. We, at some point, might need to call hospice and have them come out if we can't make sure they're safe. So these are some other symptoms you may encounter, not as frequently. Increased secretion, so those noisy respirations. Most of the time, it's going to be the Levsin. I can never say that, hyoscyamine. One of the biggest things you can do for them, though, is make sure they're pulled up in the bed and kind of reposition on the side. If that way it's not, those secretions aren't laying in the back of the throat. Nausea, there's usually a few medicines that are available to you on those sheets. So you're going to most likely be looking at the pink sheets for what's for nausea. You can try some ginger ale, some clear liquids, eat slowly. Just like if you were sick to your stomach or one of your kids, right? You're going to try to help them ease up, but make sure you go ahead and give them the medicine that they have ordered for it, so that no one wants to be nauseous. Insomnia, they can't sleep. Sometimes they have melatonin ordered. There's Benadryl, Trazodone. So if they're not able to sleep and we don't have anything ordered, obviously try some tea, a quiet environment. But you're going to let hospice know so they can try some of these so that they can get a good night's sleep. There's nothing worse, and pain's worse when you're tired. So you're let hospice know if they're not sleeping. Diarrhea can be from medicines, food. It can be caused from the disease. And this is, the medication is usually going to be Imodium that we're going to see. And you're going to want to make sure they're drinking more, even just water, because that way they're going to be able to, they're losing a lot of liquids with diarrhea. So we want to make sure that they are replacing those fluids. Loss of appetite. This can be for a lot of reasons. The diagnosis, the medicines that they're on, and there's really not medications that can help this. not very well. Sometimes a steroid might, but most of the time, this is just part of that disease process and that movement along that journey. So we're going to try to do meal replacement drinks. So do they want an Ensure, a Boost, those things, small meals? What do they want to eat? Anything that's small, a little pudding, easy things that they might eat, and just, it's kind of a game of guessing what might work and what might not.